Okay, so I want to congratulate you all on the exam. This is the highest average I've had so far.
You're great teaching.
This is a great class. But Jack and I went through the exam and we found some questions that were not above board. So, how many were there, Jack? 3 or 4? I think there was 3 or 4 that when Jack and I went over them, if he didn't argue them, I did. So just a little explanation. So I pulled these questions off the question bank for the for the book. And when I look at the question, I'm like, oh, that's a great question. And I look down through the answers, oh, those are great options. And so I add it to the exam. I have to do a couple more steps to actually see what the test bank said the correct answer was. And I don't take the time to do that. So maybe I should, because some of them were kind of a little iffy. But anyways, if people have specific questions about the exam, we'll talk about it at the end if we have time. If we don't have time, I know you guys are in mental health after this, so just send me an email and I will review that question and let you know what I decide. Okay? But anyways, kudos, even with all the bad questions. So I just want to take a second to talk about the assignments for OB. There's 2 of them. And the reason why I want to go over them is because I am getting the feeling that one has been forgotten about and the other one is a little confusing. So the one that is, I think the OB project is the one that's getting forgotten about, okay? So the OB project, remember, you pick a topic, and here's where you can pick your topic. So, wait. Yeah, we're going to talk about it too, but that's not what I wanted to do. So, in Moodle, you can click on OB project choices and just select which one you want to do. The reason why I think people have forgotten about that is because I've asked about that in post-conference and people are like, what? What? So this is similar if you had me last semester. You're educating your patient. Please remember I am going to dock points if your paper is not written as if someone sat down and transcribed your exact education session with your patient. So it's kind of weird to write that, but you write it as if you're sitting right in front of her and telling her the education. Okay. Anyways.
And you said we could use our book as one of the references.
You can use your book. You can use the resources at the hospital, or you can use the library resources here. But no Wikipedia, no Metapedia, no Mayo Clinic, no.
How are we adding references if we're doing it in a talking narrative?
You use your references. You don't. I don't want that. I don't want in-text citations, but I want your references at the bottom.
Okay.
So
no direct quotes.
No direct quotes. This is you talking to her, and if you're talking to her, you're not going to directly quote a book because she's not going to understand it.
I was going to say, most likely it's going to be simplified. It's going to be pretty simplified.
Yeah, I want it pretty simplified. So when you tell her what her diagnosis is, basic stuff, not basement pathophys, okay? Just basic stuff for her to kind of understand what's going on, okay? We're not.
She's at 5th grade level.
She's at a 5th grade level, okay? So just really basic stuff.
When is this due?
This is it March 23rd?
Yeah.
It says that there's an instruction sheet on Moodle as well.
Hey Wendy, is it possible to change what we put, because I didn't realize that I assigned myself a topic, and I went in to give myself a topic I wanted now,
Yeah,
and I already had a topic.
okay.
Can I
Yeah,
change it or no?
one of the main reasons why I want you to select your choices is not because I'm going to hold you to that. It's just helping me kind of decide that I think everybody is still doing their project. I don't want to be at the end of the semester, because I checked this. There's only 13 people signed up. So my concern is, did the other 5 people forget, or did they just not click? Okay? So if you click, then I feel better that you didn't forget. And then if you did forget, then it's off me. Okay? I don't like responsibility. Okay? All right.
If you change our topic, that's not really an issue.
If you change your topic, it's not an issue.
If we like.
But I just want, I mean, you don't have to change it on there, but I just want to make sure you guys remember this project and not come to March 23rd and say, oh, I forgot.
Boundaries, Wendy, it's not your problem. Let it go, let it go.
All right. Now, the cues and reflection. So I want to, this, okay, so this, the way I typed this, the first, number 1, I had one student, I think, this messed them up. So I want to clarify this for you. So it says, based on the patient you cared for during your OB clinical experience, give one example from the list below. I'm going to take that out. Okay, I'm going to say, give one example of the care you provided that encompasses each of the 6 competencies. So I don't want you just to pick patient-centered care and write me a paper. Okay, I want you to tell me how your care addressed each one of these issues. And then some of them, like patient-centered care, as it relates to your patient's cultural and religious practices, there may not be something very specific. They could just be a good old mountain man, okay, or woman, I mean, you know, with nothing. But most people have something, even if it's not like a Hispanic cultural practice or an Asian cultural practice. Maybe it's a interracial culture thing. Maybe it's a gay lesbian couple thing. Okay, so there might be. I mean, talk to your patients. This is how you're going to find the answer to this. Spend time with your patient. You have time to do that. Okay. Instead of sitting at the desk waiting for your nurse to go do something, go visit with your patient. Ask them questions. You know, sit down in a chair and make it seem like you're interested in who they are. Okay. But anyways, so I just want an example of each. And if you can't, for the cultural part, if you absolutely cannot identify something, make something up. Okay. Make something up.
Make it good, Jesus.
Make it good and interesting. I want to laugh when I read your paper. All right. Okay, any questions? All right, let's move on, because I think we have, oh, shoot. Oh, that was recording. Good. Okay. I think,
Yeah, last time you said you were going to split our tires if we had to.
yeah, that was silly. All right. So, so fetal activity. So we're assessing fetal well-being. So usually for you guys in the hospital, this begins about 28 weeks when we can do the in-hospital kind of stuff. There's a lot of fetal assessments that we can do in the clinic. But right now we're going to talk about after 28 weeks. So one of the easiest things to do is have the mom do that fetal kick count. Okay? Sick babies don't kick. Okay? So this is one of the big education things we do in the clinic and in the hospital. Please let us know if you're not feeling the baby move. Okay? And there's some parameters. So if you feel less than 10 movements in a 3-hour period, or a very decreased movement in a 24-hour period. So you go through your whole day, you go to work, you come home, you make dinner, you sit on the couch. Oh, I didn't really feel baby move today. Maybe you didn't feel it, but baby probably moved. You just were so busy doing your day. So we make sure that they don't call us, oh, I've been sitting here for 30 minutes and I haven't felt my baby move. Oh my God, oh my God. So no, calm down. We want you to take a 3-hour period. Or even if you cut that in half, take an hour and say, get yourself something to eat, something to drink, sit in a quiet room, don't be watching TV, and concentrate on your baby, okay? And then usually they feel these movements, okay? But in a 3-hour period, we want at least 10 movements, okay? And if they don't get those movements, then they need to call us, and we'll have them come in to the hospital, and we will do a non-stress test, but let's follow the etiological progression of the slides. So, you guys, if you remember, we can do the abdominal ultrasound, the transvaginal ultrasound. These both visualize the placenta and the baby and the amniotic fluid level to help determine how well baby's doing. So early in the clinic, we can determine gestational age. We can see the heartbeat. We can see breathing movements. We can estimate the fetal size. When we estimate the fetal size, we kind of correlate that with a normal gestation, and that's how we say, well, you're this many weeks pregnant. We use it to help screen for anomalies in the baby. The Down syndrome test, which is the nuchal translucency test, is done by ultrasound, and we look at that fold around the neck, and it's filled with fluid, and the thicker that fold is, the more risk that baby is for having Downs. And then, if that's the case, then we look at, does the baby have a prominent nasal bone or a nasal bone at all? And then there's also the shape of the face, the angle of the face that they can look at and say, this baby looks kind of Downs. And then maybe they would draw some blood from mom and do some serum testing, okay? But anyways, we can look for cardiac defects. As I said, we can check the amniotic fluid level. We can check out the placenta. We can look at the baby and see which way the baby's positioning. And of course, if we can detect a heart rate, we can also detect if there's not one, so fetal death, okay?
I have a question. If
Yep.
the parent in no way is going to abort the child, is there any point in doing those tests?
Okay, so if the woman is like, if my kid has Downs, I'm still going to follow through with this pregnancy, she may want to say, go ahead and do those serums so then maybe I can start preparing. Okay? Maybe I can start preparing for all the programs that are available for people that have children with Downs. Okay? Or she just may say, I don't care, I'll wait and see, and then go from there.
But there's no medical intervention that's really going to take place.
There's nothing we can do to fix that. So, anyways, this is just a nice little summary of what we can do at how many weeks gestation. Okay. All right.
How much are you gonna hold this to us for the test? Are you gonna be like, what week can you assess fetal?
No. I mean, if anything, there might be a question on there. If your patient is in her first trimester, what options does she have to do ultrasound or do blood testing? Okay, so in general. So the first trimester, we could do the chorionic villus sampling where we take a little scrape of that chorionic villi, okay? But we can't really do an amniocentesis in that first trimester so much because everything's so small, okay? So we usually wait to the second trimester to do that. So, and then ultrasound, of course, can be done at any time throughout pregnancy. And the serum testing is usually done in the first trimester, so, which we're going to talk about. Oh, no, we're not. So the Doppler flow studies, I would love to see one of these, and I have sent some patients or some students with Dr. Fawcett, taking a patient up to Dr. Fawcett and doing an ultrasound, and sometimes he does these in his office. Okay, these are done by ultrasound. They're non-invasive. What they're doing is they're looking at the red blood cells in the cord. Okay, and So when they look at that, it produces a waveform on their ultrasound machine. And the top of their waveform is the systolic peak, and the bottom of the waveform is the diastolic peak. And then they do a division of those numbers, and they get the SD ratio, okay? And from the results of the SD ratio, they can say whether or not there's good blood flow from the placenta, and if there's good uteroplacental sufficiency, okay? So the normal value is generally less than 3 at term, okay? So anything above 3 at term is abnormal. They can do this test as early as 16 to 18 weeks, and then up to about 26 weeks, they want it to be 2.6 or below. And then as they get closer to term, they want it to stay below 3. Okay? So if we do this test and we determine that we have a pregnancy that has uteroplacental insufficiency, then we're just going to monitor this patient probably every week. We're probably going to do a Doppler study every week just to keep track of how well this baby is growing. We'll do measurements of the mom's abdomen to make sure that's a great way to check to make sure that pregnancy is growing, okay, according to the weeks of gestation. So we just stay on top of it. And then if we get to a place where the Doppler study is really bad and we're not getting growth and we're having bad heart rates on our strip, we might want to start talking about delivering this baby, no matter how many weeks gestation. So if she's 26 weeks gestation and we got a baby that's not growing and has poor Doppler studies, that baby might be better off delivered at 26 weeks. Okay? So we need to kind of weigh what environment is best for baby. Now here's the big one. Non-stress test. If a patient walks into the hospital pregnant, she gets a non-stress test. We don't really have to have an order for it. Well, we do have to have an order for it, but we don't have to call the doc and say, hey, I got your patient. Can I do a non-stress test? You put them on the monitor and you do it, okay? It's a great assessment of fetal well-being. It tells us if we have an oxygenated baby, okay? We can start doing this test at 28 weeks. The baby's central nervous system may be mature enough to start doing this test. So if you put a patient on at 28 weeks and you don't get a passing test, is there something wrong with the baby?
Not necessarily.
Not necessarily, okay? Maybe this is too early for this baby, okay? But between 28 and 30, 32 weeks, that central nervous system needs to be maturing somewhere in that range, okay? So if you do a test on a 28-weeker and she passes and the baby passes, the baby should always pass, okay? If the baby doesn't pass, then baby has a problem. It's no longer an immature central nervous system. If they've passed once, they should always pass, okay? All right. So if you remember, I don't know how in depth I went over this last semester, but this is going to be kind of confusing, how we report whether or not this patient passed the test, okay? So this is an NST, a non-stress test. We're seeing if our baby is non-stressed or not stressed, okay? So what we look for is we look for accelerations. We need to have those standard 15 beats above the baseline for 15 seconds. We need 2 of those in a 20-minute period, okay? If we don't get 2 of those in a 20-minute period, then we extend it another 20 minutes. Because in general, baby sleep cycles are up to 40 minutes, okay? So at 40 minutes, if we haven't been able to pass this baby, then we might do another test, something else, something different, okay? In that 40 minutes time, I might try to do something to wake baby up, like I might give mom a very cold glass of ice water. We have these things called acoustic stimulators, and they're just this little microphone-y thing. You put it on mom's abdomen, you push a button, and it kind of vibrates and makes a noise, and it sounds like this. Okay? and that usually scares the crap out of the baby, and baby goes like this, and then we look to see if we have an acceleration, okay? This little caveat here, preterm babies, so we can look for accelerations 10 beats above baseline for 10 seconds, okay? Anyways, so we look for that. And if we find that, if we have those accelerations, then the baby passed the test, okay? But we don't say baby passed their test, we say baby had a reactive non-stress test. So baby, reactive is a positive word. It means positively baby was non-stressed. It's really kind of weird, but you're going to see how this plays out when we look at another test. But if baby passed the test, we have a reactive non-stress test. Okay, our baby is non-stressed. If we do not pass the test, we have if baby actually fails the test, we have a non-reactive, non-stress test.
Say that again.
We have a non-reactive, non-stress test. Okay, yes.
Back to the previous slide, it said a preterm fetus. How, if it's not born, how do you know it's going to be preterm? If the baby's not born yet?
So preterm is any pregnancy before, well, for a non-stress test, it's any baby below 32 weeks
Oh.
gestation. Okay. All right. So so if baby failed the test, then it is a non-reactive, non-stress test. Unsatisfactory just means, you know, maybe the baby was moving like crazy, and you couldn't keep tracing the baby on the monitor, so you didn't have enough tracing on the strip to make a determination. Or baby was totally inactive, and you couldn't get the baby to be reactive, so so you call it unsatisfactory.
Why would we just say non-reactive?
Non-reactive is so you get the movements, but they're not accelerating or they're decelerating, okay? If you can't get baby to move to be able to interpret the test, then it's not necessarily a fail, although that's what you're kind of thinking, because if I can't get this baby to move, then maybe something's wrong, because sick babies don't move, okay? Now here's an example of a reactive non-stress test. The baby passed. We have all these marks down here that say FM. So those indicate fetal movement because mom felt it and we gave her a button and she pushed it every time she felt the baby move. And in response to these fetal movements, we have accelerations. Okay? So, yay. This looks beautiful.
That bottom tracing, her holding the button down creates a larger spike.
Yeah, so when she hits the button, it just creates a spike. On some monitors, when she hits a button, like the monitors at CMC, it'll actually be an arrow. You'll just see a dark arrow where she hit the button. Some of them, depending on where we plugged that button into on the monitor, it'll be a little musical sign. Anyways, okay? So, depending on the monitor, the brand, what they do. Okay, so here's a non-reactive, non-stress test. The baby absolutely failed. It wasn't inadequate. We've got several marks of fetal movement and we have absolutely no accelerations. Okay, so this is a non-reactive, non-stress test. If there was no marking of fetal movement, if she did not feel fetal movement at all, then we would say this is unsatisfactory because we weren't able to get the baby to move to interpret what the heart rate did. Okay? Now the other test, and this is why those terms on how we report the findings can get confusing, is if we do a contraction stress test. And we don't do these very often. We do non-stress tests every time we see a pregnant woman, okay? A contraction stress test is very specific. It is a determination of fetal well-being, but what we're asking ourselves here is, can this baby tolerate labor? Whereas the non-stress test, we're just doing it to assess fetal well-being. We might be doing it 28 weeks. We might be doing it every week until she labors, okay? But this one, we want to know, is this baby going to tolerate labor, okay? It's called a contraction stress test. So we need contractions. Here is your absolute contraindications for doing a contraction stress test. What I want you guys to try to start doing is, instead of memorizing these things, think about what this means. Think about what it means to have a patient contract. And think about what it means for a patient who is high risk, who you don't want contracting. A bleeding patient with a placenta previa. We don't want that girl contracting, okay? So why I want you to recognize these, but if you see these on an exam, I don't want you to think, okay, what did I memorize? I want you to look at these possible choices on the test question and say, do I want a patient with a cerclage to contract? Okay? So it's not really a memorization thing here, guys. It's a, you're the nurse and you're using your knowledge about what contractions do and why you don't want these people to contract. It's very, yes?
If it was a priority question, are those all equally priority?
Yeah,
Like,
yeah, I mean, yes. I mean, it's not like, okay, so,
there might be instances where they would do, where the benefits outweigh the risks. None of these is that case.
right, right.
Okay.
With multiple gestations, is it just because she contracts faster, so she's more...
So that one is one that is a kind of, okay. And the reason why I said no is because for a test, the answer is no. Okay, but if we have a twin gestation that we will allow to labor and deliver vaginally, we might do this. But anything beyond a twin gestation, they don't get to deliver vaginally at CNC or at St. Pat's. They get a C-section, period.
Really?
So,
Say that again?
okay. So a twin gestation, we will allow them to attempt to labor and deliver vaginally. So we might do a contraction stress test on a twin gestation, because if we put them in labor, we're okay with that, okay? But anything beyond a twin gestation, they get a C-section, period. They don't get a trial of labor, they get a C-section.
Is that evidence-based or is that
Yes.
just liability?
No, that's, well, yeah.
Kind of both.
Okay? All right. So the way we do a contraction stress test is of course, we put the woman on the monitor, but we need to get her to have contractions. So there's two ways we can do that. We can start an IV and start running Pitocin, or we can have her do breast stimulation where she's actually rolling her nipples with her fingers. Okay? But anyways, we want to see 3 contractions in a 10-minute period that are 40 to 60 seconds, that they last, each of them last 40 to 60 seconds. Okay? Once we get that contraction pattern, we stop whatever we're doing to cause contractions. So we turn off the pit, we tell her to stop doing breast stimulation, whatever it is. Once we get the contractions, then we interpret what we're seeing on the strip. Okay? So in order for this baby to pass the test, they have to have no late decelerations. Okay? They don't have to have accelerations. They just have to have no late decelerations. Okay? None. Not even one. If she has 4 contractions in 10 minutes, and she only has one late deceleration, she just failed the test, okay? Well, she didn't pass the test, okay? I'm sorry, she did not pass the test. So if she passes the test, we say now that she has a negative contraction stress test, which means she's negative for stress during a contraction. See how that's kind of opposite the non-stress test and can be quite confusing?
Can you say that one more time?
Okay, if she passes this test, then we say she has a negative contraction stress test, meaning she is negative for stress during a contraction. Okay?
Meaning the baby should be okay during labor.
Meaning the baby should be okay during labor. Okay? So,
It says no late decelerations. I thought that it said no decelerations, period. Is it only late?
it's only late.
So variable decelerations are okay.
We'll talk about it.
Oh.
Okay? Okay? We'll talk about it. All right? So if she has no late decelerations, then she's passed the test. What does a variable deceleration tell us?
Cord compression.
Cord compression. Why do people have cord compression? Huh?
Wrapped around the baby.
Wrapped around the baby, low amniotic fluid. Can these people do labor? Yes. I mean, we have those situations. We can try to fix the low amniotic fluid. We can try to fix the cord compression by moving mom. Maybe when she's ruptured, we can do an amnio infusion, and we'll talk about that sometime. But variable decels do not disqualify a person from having labor, because many times we have variable decels depending on the environment in the uterus, and they can still go on to have a vaginal delivery, okay? But late decelerations, no, 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 okay? So what that's telling us pathophysiologically is that we have normal uteroplacental sufficiency. We've got good oxygen exchange going through there, okay? So if we have good oxygen exchange, well, what we're thinking is the baby can tolerate the stresses of labor, okay? Now, if they fail the test, to fail the test, they have to have recurrent or persistent, whichever word you want to use, late decelerations. Does anybody remember what recurrent decelerations mean? Greater than 50%. So if you have 4 contractions in your 10-minute period and she has 2 late decelerations, she now has recurrent decelerations. If she has 4 contractions in 10 minutes and she only has 1 late deceleration, she does not have recurrent late decelerations. Okay? That's important because she has to have recurrent late decelerations, and then she fails the test. If she fails the test, we say she has a positive contraction stress test, meaning she positively has stress during contractions. Okay? Now, equivocal or suspicious is the patient that has the slide put non-persistent late deceleration, so that means she just had the 1 late deceleration. But this would also be if she has anything else really bad about her strip, if she has tachycardia with her strip. Okay? Tachycardia means the baby's heart is pumping very fast because they're trying desperately to get enough oxygen to their tissues. Okay? So that baby, so it's suspicious. Okay? So this baby might have variable decels. Okay? It's not written up there, but anytime you have something bad looking non-normal with your strip, that is suspicious for baby's ability to tolerate any stress. Okay? So if we do want this person to labor, if she's like, I don't care, do whatever you have to do, I want to have a vaginal delivery. So we'll go as far as we can. If baby tolerates the labor with all our constant interventions, and I've been that nurse for 12 hours, I want to shoot myself in the brain. I'm a nervous wreck the whole time because I'm just waiting to call a stat C-section, okay? But anyways, if they make it to delivery and deliver vaginally, great. But we're going to definitely be on our toes every second of this labor, okay? So here's your positive contraction stress test. Baby is positively stressed with these contractions. You can see not only recurrent, but with every single contraction, the baby is having a late deceleration. Yes?
If they're not on the floor, at what point are you involving the physician?
Well, he ordered this for one.
Yeah.
So like when I said the non-stress test, you don't need to call the doc and say, hey, can I do this? The doctor will say, I'm sending the patient over for a contraction stress test. And then once you finish the test, you call the doc and say, ain't gonna work. Okay? Did that answer your question? Okay.
You didn't cover this. When does he call the contraction stress test?
When does he have you do
During
it?
gestation? Yeah.
Well, usually it's close to term. We don't want to do this on a preterm person, okay? Because we don't want to put a preterm person in labor unless it was a situation, and this is the doctor's decision, unless it's a situation where he says the baby is safer in the NICU than the baby is in utero. We have to get the baby out. So let's try a vaginal delivery. We have done that. We have done inductions on 32-weekers, okay?
Because no matter what, this test could be a point of no return.
Right. This test can be a point of no return. You're making someone contract, and then when you get that contraction pattern, you need to stop everything. But if you stop everything, she might not. She might just keep going with contractions and start laboring and dilate and deliver her baby. So you only want to do this test on people that ultimately you do want them to have a labor. We're just seeing if the baby can tolerate a labor. If this is on someone we need to have delivered, okay? So if she's 32 weeks and we don't want her to be delivering, we're not going to do this test. But if she's 32 weeks and we know we need to get that baby out one way or other, we can try to do a labor, but we need to see if this baby's going to tolerate it. If the baby's not going to tolerate it, we go to C-section. Okay? This is not something that we're going to do and then say, okay, you passed or failed, whatever, go home. We know what we need to know now. Go home.
How likely is it, in saying somebody is at 32 weeks, that the concern of why you're doing this test, that the baby is going to pass this test?
I don't know, 50%, I'm just throwing out a guess.
But it does happen.
Yeah, it does happen.
So what would be, can you remember a situation where the doctor had this concern, but the baby handled the stress of the uterus?
So we have a woman who's severely preeclamptic, and the best treatment for preeclampsia is delivery, get the placenta out of there. She's 34 weeks, she's 33 weeks. We need to get the baby out. Maybe the baby's fine,
Okay.
but the mom is not.
Okay, yeah. I hadn't thought of the perspective of the mom.
The other issue is, I mean, you know, there's lots of, she may have a heart, mom may have a heart problem that she's starting to have a lot of symptoms because of the overload of the pregnancy, and her heart is not going to take continued pregnancy. We need to get the baby out for mom's sake. So a lot of times these aren't baby issues, they're mom issues. But an instance where it's a baby issue is maybe we do have a twin gestation, we have a twin-to-twin transfusion, and we're going to lose that donor twin if we don't get them out. So yeah, maybe the donor twin looks bad on the monitor, but does it look bad enough to not do a vaginal delivery? Okay, or maybe we just got a singleton pregnancy with chorioamnionitis, and baby is still doing well. But if we leave baby in there with that infection, we might be, you know, risking a septic baby on delivery. So there's all kinds of things we can come up with.
I have a quick question. Why What causes the decel? Like,
The late deceleration?
yeah, what, like,
So, okay, so it's,
physiological
okay,
going on?
so it's uteroplacental insufficiency. So without contractions, the blood flow on the mom's side and the blood flow on the baby's side, so the oxygen transfer is not good, okay? If baby is not contracting in a stressful environment, so baby's just kind of skating along with the minimal oxygen exchange, okay? But then when we put a contraction on it, so the contraction is now squeezing all those vessels that empty into the decidua basalis below the placenta, so that where the blood from the mom comes to the placenta, so that's being contracted. So now we take a uteroplacental insufficiency at rest, and then we make it worse by contracting the uterus, which contracts those vessels. So now we're further diminishing the oxygenation of the baby
Okay.
and the blood getting the exchange going on. So we have the contraction, it starts to squeeze, and then the baby's heart is like, oh my God, like I can't do this, I can't even breathe or oxygenate. Okay.
What about with the stress test? Why? Because that's without the contraction.
Yeah.
How is baby able to move essentially, and like why would his heart rate go down with him moving?
So in a non-stress test?
Yeah.
Okay, so if you have, so like I said, sick babies don't move. So it's almost the same principle, okay? So we're looking at oxygenation or fetal well-being. So when baby's not moving and not doing anything and just skating by, okay, so then we just have, we just have this baby sitting like this, okay? When something happens and baby moves, that's too much stress on the heart, just like you running upstairs, okay? So when baby moves, if baby's oxygenation status is not strong enough to create an acceleration in the heart rate, then the deceleration happens, or no response from fetal movement. Because with fetal movement, we should see an acceleration. Just like when you run upstairs, you should feel your heart rate increase a little bit. It's normal, okay? But a heart that's stressed, under stress, deoxygenated, is going to just try not to react to anything, because if it reacts, it's going to crump.
Makes a lot of sense.
Is that why early decelerations are a healthy indication, whereas late deceleration isn't?
Yeah, because early decelerations have nothing to do with oxygenation. Early decelerations are the head is getting compressed because baby's coming down through the birth canal. It's a vagal response.
Okay.
So if I squeezed your head with a vice, your heart rate would drop. So when that, yeah. So it has nothing to do with oxygen, okay? It's just a vagal response, and then it's over. Yes.
How often does what you're seeing here that's a problem correspond to after the baby's born, them having some sort of heart problem, or is it just
Right.
usually a labor problem?
Majority of the time, it's just a uteroplacental problem. So when baby gets out and starts breathing oxygen on their own,
They're fine.
usually they're fine. If it's a preterm situation, that can be different. If baby was in an oxygen-deprived environment long enough that the asphyxia is now extending to the blood, or to, it's in the blood, but to the tissues, so hypoxia, where it starts damaging the tissues, then when that baby comes out, we might have a problem, even if it's a term healthy baby. If it's been stuck in an oxygen-deprived environment long enough, then they're going to use up everything they have, and they're going to be worthless when they're born. Okay, basically. All right. Okay. You guys got this. You can talk it through. Talk it through your brain. Okay. Talk it through your brain. Okay. So you did the non-stress test, and baby either failed and had a non-reactive, non-stress test, or you had that baby that wouldn't move at all, so you had that equivocal, unsatisfactory test. So we need to check further, and we do this biophysical profile. There's 5 components to the biophysical profile. 4 of them are assessed during an ultrasound. The 5th one is your non-stress test. So if you did the non-stress test on the baby and they failed, and the doctor said, okay, do the, or even if it's suspicious and unequivocal or whatever, and he says, do the biophysical profile, baby just failed one of the variables to the biophysical profile. Okay? So now we're going to assess the other 4. And with each one of these, baby gets either a 2 if they pass or a 0 if they don't. Okay? So baby already has 0. All right? There's 5 parameters, 2 points each, a total of 10. Okay? So baby's already got 2 points off. All right? So the other things we assess are breathing movements, fetal tone, and amniotic fluid level. Okay? So breathing movements is baby's not in there breathing 40 to 60 times a minute like they do when they're born, but they do breathing movements. Okay? So they want to see that. They want to see the arms and the legs move. Okay? So on the one where mom felt baby move but didn't have an acceleration, well, we know baby's moving, but on the one that mom didn't feel baby move, so we couldn't interpret the test, maybe she just wasn't feeling them. But maybe baby is moving. So baby might get a score here. Anyways, we're looking for tone, and just like we look at tone on babies that have been born, you know, a relaxed, straight arms, straight legs is poor tone on a baby and a fetus. And we want to see everything contracted in, or, you know, flexed in, okay? So he'll get a score there, and then they'll measure the amniotic fluid, and they'll get a score there.
This is assessed with ultrasound?
This is with ultrasound.
Have you ever seen one of these asked for where they didn't, or where they had a reactive non-stress test?
Yeah, we've done these when they've had a reactive non-stress test. It's just a more thorough assessment of fetal well-being. And if it's a patient that comes in and says, oh, I didn't feel baby move today, and we do a non-stress test, that's probably all we're going to do. But if there's maternal indications like she has high blood pressure or gestational diabetes, if she has a heart problem, if there's a maternal problem, or if there's a known baby problem, we might go ahead and still do the biophysical profile even though we did the non-stress test. Okay, it's a more thorough assessment of fetal well-being.
So is it more common to see this with?
It's just more common to see it when they don't pass their non-stress test.
Okay.
Yeah. Okay, so we get a score of 2. If they pass, a score of 0. If they don't pass, maximum score of 10. And here specifically is what they're looking for. I don't care. I don't need you to know, you know, the specifics about what they're looking for on the ultrasound. I just want you to know they get 2 points for each one of these. The ultrasound tech is going to call you and say, baby scored 8 out of 8 on my test because you have the 5th test. You did the 5th test. They're going to say, your baby scored 8 out of 8, or your baby scored 6 out of 8, or something like that. Okay? And you can ask, what did they get docked on? Well, I didn't see any movement at all, or not enough amniotic fluid, or something. They'll, you know. So you don't need to know these specifics. Okay? So if a patient scored 0 on your non-stress test and they got 1 mark off on the ultrasound, so that's 4 points off, so now they're 6 out of 10. Okay? They probably just bought themselves a room at the hospital. Okay? That doesn't, 6 out of 10 does not necessarily mean, well, we need to get them delivered right now. Okay? The physician will look more closely at the ultrasound and see what the issue was in the ultrasound, and he'll determine whether or not we want to sit on this patient, continuous monitoring throughout her pregnancy until the time is we need to deliver her. Okay? But if she gets 4 or less, we're probably going to deliver. Okay? So if she gets 4 or less, and this woman wants a vaginal delivery, what do you think we might do to her once we get her back to labor? What test? Contraction stress test, okay. Well, let's see if your baby will do it. Your baby is puny, but we'll see, okay? And then we might do a contraction stress test to see if she'll labor. And then if baby won't labor, then we'll do a C-section. Okay, here's a lovely amniocentesis. This is how we take some amniotic fluid and we go do some tests on it. It's done by guided ultrasound. So the physician will do the ultrasound, and sometimes they'll leave that on there as they insert the needle, and sometimes they'll put that on there and they'll put a X in the spot where they have a pocket of fluid, no placenta, no limbs, no baby. Okay?
And then they take it off?
Huh? And then they might take the ultrasound deal off if they mark their spot. Huh?
The baby moves.
Well, it's that quick. So they put the ultrasound on, they mark their spot, you're the nurse, you hand him his syringe, he hands you the thing, plump, plump, done. Yeah.
I've heard it's not as risky as the statistics.
So,
indicate.
yeah. So the risks are causing her to rupture her membranes, causing an infection, causing bleeding. That's a risk, well, except for rupturing her membranes. That's a risk anytime you enter the patient's body with object, okay? Even doing an IV insertion, you could risk them bleeding or getting an infection, okay? But because we're going through the amniotic membranes, we can risk causing those to rupture. If our physician doesn't identify where the placenta is and he goes right through the placenta, that's not good. And if he takes the ultrasound off and waits 5 minutes and then and the baby turns, then we might poke the baby, you know. But yeah, they're relatively.
What is your experience on that?
I've not, of the amniocentesis that I've been involved in, I've not ever had a patient go into labor because of them or have any bleeding or infection issues or any placenta baby issues. So, yeah, I mean,
You've never seen a
I've never seen any negative consequences from an amniocentesis.
Last night after I took the quiz and had gone through these slides, I was looking through the channels on PBS, and it right when I clicked on the channel, it had a picture. It was a close-up, and you could see the syringe going into the skin with the yellow fluid coming out, and then it panned out, and they were injecting a chicken to put on the grill.
Oh.
But it looked exactly like an amniocentesis.
Yeah.
OB on the brain.
Yeah, and it even had like the yellow fluid in the syringe and everything.
Right.
It's so funny.
They don't do these as much anymore because of the serum testing that they can do on mom as far as identifying fetal anomalies or something like that. They do this more to test for fetal lung maturity. So we test the amniotic fluid for certain components, proteins and such, to determine whether or not we have fetal lung maturity. And if we do, then we'll induce or do a C-section, okay? So an amniocentesis for fetal lung maturity is probably, we're doing this on a 36-weeker or a preterm. And so the standard, the ACOG, American College of Obstetricians and Gynecologists, say that when you're inducing a woman, or when you're going to deliver a woman that is preterm, then you need to have your amniocentesis results. So if you're inducing her because of a medical or obstetrical reason, irregardless of whether we have fetal lung maturity, you have to have a medical or obstetrical reason to do it early. And then they do want to see the lung maturity results. Now, if you get lung maturity results on a patient you know you have to deliver, and those lung maturity results say the baby's lungs are not mature, are you going to hold the delivery? No. You need to get the delivery done. That information is going to help the resuscitation team and or the NICU. okay, in preparing for this baby, okay?
Is that surfactant?
Huh? So yeah, they'll get surfactant ready.
Yeah.
So, one of the tests they do does test for a protein in surfactant, and we'll go over that. But they're really getting strict about inducing people electively with no medical or obstetrical reason. Even at term, they're trying for us to get away with inducing people, even at term. But if someone was adamant on inducing a woman who was not term, who did not have a medical or obstetrical reason, you would definitely want to do an amniocentesis so that you can prove fetal lung maturity. For instance, if, and I'm telling you this is going out of favor, but we have a lot of people in the military, a lot of husbands who get this little window where they can come home. And they'll sometimes, I've seen amniocentesis is done on a 37-weeker because husband was going to be back in the States and wanted to be there for the delivery of his child. They did an amniocentesis, and if there was fetal lung maturity, they would go ahead and do the induction. Okay, but that's going out of favor anymore because you don't have any, even if you have fetal lung maturity, you don't really have any leg to stand on because fetal lung maturity doesn't have anything to do about brain maturity, and it doesn't have anything to do about the consequences to mom for causing an induction. Because a lot of times when you induce someone early and their body is not ready for that induction, they won't. Sometimes they won't deliver and they end up with a C-section. So now you have all those consequences, okay? So anyways, that's just a tangent, but
It
so
used to be a very accepted thing.
yeah.
I was.
Oh yeah, we never used to do fetal lung maturities. You want your baby because you live 50 miles from the hospital and your truck doesn't work well, and this is the only time you can catch the horse and carriage into town, and okay, we'll go ahead and do your delivery, and okay, so they used to do that all the time.
How long does it take to get the results back on that?
If you have a facility that does them, oh gosh, I don't even remember now. I think maybe our slides tell us. So here, let's look at this one. It doesn't tell us. Some of them are pretty quick, within a half an hour, depending on what test, and some of them are longer. And then if you have to send it out, then you're even longer, okay? But this is the main one. This is the one that, this is the oldest one, the one they've done for years. It's called the LS ratio. And these two items are components of surfactant. So we're seeing if the baby has produced an adequate amount of surfactant to keep their lungs open, okay? And then ultimately, we want the LS ratio to be 2 to 1, okay? And if we have an LS ratio that is 2 to 1, then we do not think this baby will have respiratory issues. And keep in mind, I said we do not think. So, you know, low risk for having respiratory problems if we deliver with an LS ratio of 2 to 1. This is the one I have the most experience with. Okay, so this fluorescent polarization test, I am not at all familiar with. You know, it's a measurement of the ratio of surfactant and albumin. This is a quick one, depending on if your hospital does it. And then if your results are above 50, then you probably have lung maturity, okay? Another.
Is it very common to see the baby's lungs in a different state than you would think they were?
So if you do a fetal lung maturity and you think you have lung maturity,
you think that
and
the kid is 33 weeks, like.
And you're not expecting them, so what's your question? So,
My question is, are you ever really surprised by the LS?
not so much. So,
Is that-
not so much. So if we got babies between 34 and 36 weeks, so we never know. So a baby at, especially like a girl baby, with a diabetic or preeclamptic mother, we're going to expect her lung maturity to be higher than even a boy baby with the same mother. Okay. Now there's a theory that babies that have mothers with medical problems is they get some sort of signal and they mature faster. So when they're delivered, they're a little more ahead of the game. And then if it's a girl, she's always ahead of.
Period.
Really?
I'm telling when you go to clinicals, you go into the NICU and you ask any nurse in there, if you're going to have a sick baby, which kind do you want? And I will guarantee you, 100% of them will say, I want a girl. That's the way it is. Okay, so this PG is another product of surfactant, and a lot of times we'll do the LS ratio and the PG. So it just substantiates a little more, because if the PG is present, then you have fetal lung maturity. If it's not present, you don't. There's no numbers. It's either there or it's not there. So if you have an LS ratio of 2 to 1, but no PG, you probably don't have fetal lung maturity. Okay? All right, so I've seen LS and I've seen PG, okay? It's just the luck of the draw. Whatever your facility uses, whatever your physician is used to using, that's what they're going to be doing, okay? And I've just been with physicians who do the LS and the PG. All right, and then I think this is the last kind they can do. They can count the lamellar bodies.
So if it, I'm sorry, I have a question. If it falls below that 50, 55, that's when they'll give the steroids, or they do that anyway if they're preterm?
So they probably give them anyway. They'll probably give them anyway. If they have a patient that is at risk patient that they're following, even if they start following her at 28 weeks, they might go ahead and give. They will go ahead and give the steroids, even if they. Even if they think, well, we can hang on to this patient to term, they'll still give it, just in case they can't hang on to the patient till term. But it's not, usually they've already given it. So if it's a patient that surprised them or something, and now they're doing a lung maturity and they get a baby that doesn't have mature lungs, and it's one that they do want to get delivered as soon as possible, they'll take 24 hours and they'll do the steroids. All right, so, and I've not worked with any physicians that have used the lamellar body counts. But anyways, if the count is over 32,000, then they're going to assume they have lung maturity. All right. Now, just real quick about the chorionic villus sampling. They take a small sample of the villi. They can do it either transabdominal or transcervical. It's a first trimester testing for any type of genetic disorders. This is the earliest one they can do. There's a little more risk with the villus sampling, and I hate this, limb reduction. That's baby's limbs. That's the fetus. Okay, reduction.
Why do they do this test?
To check for genetic disorders. And there's some genetic disorders, there's some trisomy disorders that are really awful. Like Down syndrome is bad, but these people can live productive lives, okay? Down syndrome, but there's some of those other trisomies are just horrific, okay? And
And they can't get that from an amniocentesis?
Yeah, but they can't get the amniocentesis until the second
So it'll
trimester.
be too late.
This is the first trimester. So if something in your history, in the patient's history, leads you to believe that there might be a huge risk, okay? You want this patient to have some sort of risk, then you do this. You just don't want to do this and say, oh, I'm pregnant, but will you see if my baby's okay? And do this. Like, that is not a very good decision because of the risks involved with doing this deal. So I don't know of any physicians that would say, oh yeah, I will do this just to see. You have no risk factors, you have no historical factors that make me suspicious of your baby having a congenital anomaly, but I'm just going to go ahead and do this because you wanted it. No, they probably wouldn't. Okay? So it's a pretty risky deal. Okay, let's go on to some fun stuff. Preterm labor, as you guys can remember, is any labor after 20 weeks, because if it's before 20 weeks, what is it? Abortion. To 37 weeks. Okay. Someone who we think is in real preterm labor, they have at least 4 contractions in 20 minutes. And this says cervical change or dilation greater than 80%. Okay, so that's an exam question. I'm not going to wait till 80%.
Is that an 8?
Huh? 80? No. So if her initial cervical exam that you did whenever, which I didn't do, I'm in the hospital, if the physician does this cervical exam and then a couple weeks later or something does another exam and he feels there's an 80% difference in her deal, then that's a criteria for preterm labor. But what I'm saying is, like, I'm not going to wait. Like, if I saw this patient and she had a 30% change in her vaginal exam, along with 4 contractions in 20 minutes, go to the hospital. You're in labor. Okay? I'd rather be wrong that way than wrong the other way. All right. So signs is, so she has contractions that occur at least every 10 minutes, with or without pain. She can just have menstrual-like cramps. So this is the one thing that's really kind of dangerous about preterm labor, is I just feel crampy. You know, it doesn't bother me, it's irritating, I can work, I just feel crampy. She could be contracting and dilating, okay? It could be constant or intermittent pelvic pressure. She, of course, can have rupture of membranes. She can just have a low backache, start having vaginal discharge. A pregnant woman having vaginal discharge. So these signs can just be really quite vague, and they can just be really quite common to pregnancy anyway. Okay? So preterm labor can be kind of a scary thing. Here's some of your predictors, and these things I don't want you to feel like you have to memorize. I want you to see how these relate. I want you to critically think through these and see a person with a multiple gestation. So a person with multiple babies in there, don't you think that's going to be a lot more pressure on her cervix and her bag of waters and just maybe kind of disrupt everything. So anyways, you can look at those. Don't feel like you need to memorize them. But when you see these things present in your patient, or you see these things on an exam, just think, how does this factor affect the uterus, affect the baby, affect the bag of waters, affect the cervix? Is it possible that these might be stresses to those things, okay? And therefore maybe cause this woman to be go into preterm labor. So we want to maintain good blood flow to the uterus. Of course, we want to stop contractions if she's having them, and then make sure that our baby's doing good. One of the biggest reasons one of the most treatable and most common reasons people go into preterm labor is dehydration. So you've got a pregnant woman who works somewhere where she doesn't have the opportunity to drink her water throughout the day. She gets really dehydrated, she's been standing all day, her uterus is dehydrated, it's irritable, it starts contracting, okay? If she doesn't correct that, she could go into labor. So a lot of times we get these women in that are preterm, that they think they're in labor, and indeed they are contracting, and we have them drink lots of water. We may even start an IV and give them lots of fluid, and then you can just see those contractions just dissipate. The other one is a urinary tract infection. So we give them a glass of water and we give them an empty cup. And then hopefully that's the case because we can take care of that. But, so maintaining good uterine blood flow. So if we beef up mom's blood volume and hydrate her, we've done that. So, but, you know, if it's a little more complicated than that, then we definitely want to get an IV going. Always put a pregnant person on their side, left side, initially. We'll draw some labs because these may tell us why she's in preterm labor, and possibly we can fix these. Okay. And then ultrasound. So the fetal fibronectin. We do this test a lot at both facilities. Okay. If we do the fetal fibronectin, I may have another slide, but this is the protein that binds the uterine or the amniotic sac to the uterine lining. So if that bond starts being challenged, then it'll shed this fetal fibronectin. And then we do a vaginal swab, and then we send it down to the lab, and then they tell us if, yes, there is fetal fibronectin, or no, there's not. If there is fetal fibronectin, then she has a high chance. I think it may be on the next slide. Wait a minute, let's finish this. So an ultrasound is another thing that we'll do. We'll measure cervical length, and then of course we'll look at the fetus and the placenta. But, so we want a long cervical length, okay? Greater than 5 centimeters. Anyways, I'm not 100% sure. But if that cervix starts shortening, then she's at risk for going into preterm labor. And also, if you see that cervix look like a funnel instead of like a tubular pipe, if it's looking like a funnel, then she's at high risk for preterm labor. Oh, crap. Okay.
Even if it's not shortening?
What?
Even if it's not shortening?
Well,
It could be like wide.
yeah, it's kind of a dual thing. So as it funnels, it shortens. Okay. So fetal fibronectin, if they find fetal fibronectin on that test, then she's at high risk for going into labor within the next 2 weeks. Okay. I've had patients that we've gotten a positive fetal fibronectin on that we've sent home on bed rest with education on signs of labor. If that fetal fibronectin comes back negative, then she will not go into labor within those 2 weeks. All right.
She won't?
Right. Correct.
So even if there's other issues, that lab's pretty definitive
Right.
on whether she's...
Right.
Okay.
If she had a trauma that ruptured her uterus, that ruptured her placenta, that ruptured her bag of waters, of course.
Right.
Okay. Okay, so these are the medications that we'll do if we can't correct it any other way. So we give, we used to give terbutaline or breathine like all the time. It's actually an asthma medication. It's not FDA approved to stop preterm labor. But just like it relaxes the bronchioles, it relaxes the uterine muscle. Okay. Patients hate this drug because their heart rate, it makes them have a really fast heart rate, and they don't like how that feels. Okay. Mag sulfate is a drug that we will give. Usually, if we give terbutaline, it's a sub-Q injection We give it, it stops her contractions, we watch her for an hour, they don't come back, we send her home. If we're giving mag sulfate, that's an IV drip, and she's a patient now. Okay? Mag sulfate, well, we're same. It kind of just relaxes the smooth muscle of the uterus and causes those contractions to simmer down.
It feels like you're burning from the inside out.
Mag sulfate is a disgusting drug. Yeah. We run a bolus in a 15-20 minute period, and in that 15-20 minute period, the patient is literally going to rip their skin off. They get this overwhelming hot sensation. They have this vague, I feel like crap feeling, maybe even a headache. And then after that 20-minute bolus, we slow it down to a maintenance drip, and then their body kind of adjusts, and they don't feel so crappy. All right, another drug that we give now more often is Indocin. We put the patients on this on a Q-hour schedule, not hour, is that 4 or 12 hours? Not important. Well, it is important, but so this is a PO medication that we give. The same thing with the Procardia. The Procardia is usually, we can put them on a regular schedule, maybe a once a day or a BID or a TID schedule. Whatever works, that's what we use. Okay? Huh? PO drug.
So you can send these people home with these medications?
Yeah. Yep.
The only one you have to hold is the magnesium sulfate?
Right. So, typically we'll try one of these PO medications, and if that works, we'll send them home on a regimen, okay, with a prescription. If those don't end up working, then they get admitted and put on MAG. So MAG's kind of our, so you try the least invasive type deal as possible. All right. So PROM versus PPROM. So PROM is premature rupture of membranes. And it's a rupture of membranes that happens before the woman ever goes into labor. Okay. Usually you think of, the woman walking through the grocery store and all of a sudden there's, on TV, there's a thing. Okay. But a lot of times what happens is her bag of water ruptures and she never even starts labor. Like on TV, like her bag of water ruptures and then it's like, oh God! And then within your 30-minute sitcom, she's delivered her baby. But anyways, so it's a premature rupture of membranes is a rupture of membranes before the onset of labor. Okay, so if she has premature rupture of membranes when she's preterm, now it's the PPROM. Okay, so she can have premature rupture of membranes and be term. Okay, but if she has premature rupture of membranes before she's term, now she's a PPROM. Preterm premature rupture of membranes. Okay. Now, if someone ruptures the membranes before term or before 37 weeks, and they're not laboring, they're not contracting, they're not dilating, we'll admit those patients to our antepartum unit and keep them pregnant as long as we can. Okay? So as long as baby keeps producing amniotic fluid, even though she's ruptured and losing fluid, as long as baby's keeping enough fluid coming to keep their status stable, we'll keep this woman pregnant as long as we can. As long as we don't have an infection brewing, we'll keep this woman pregnant as long as we can. But when baby stops dealing with this and or an infection starts happening, then we will let this woman labor.
Is that only to be that the lady can continue to remain pregnant? Is if it's like a trickle of the amniotic fluid, but not a complete?
They might have gotten a gush to begin with, okay, and then they just have a small trickle, it's not a gush, it might be a small trickle. We keep them on bed rest, so for several hours they might not feel any fluid come out, and then when they stand up and go pee, they feel this gush again. Mm-hmm. We've had women that are 28 weeks ruptured living in our facility, and we keep them there as long as we can. and we keep them pregnant as long as we can. What?
I guess I just can't, in my mind, figure out if the membranes have ruptured, then they're not losing all of the fluid. They're just losing a little. I mean, there's got to be enough to
Right.
maintain.
Right. And
buoyancy.
baby keeps producing
The baby produces the
fluid all the time, yes. And the baby keeps producing fluid all the time, and if the baby is producing enough,
Maintain an adequate amount.
yeah, then
Will
we
you
keep
do
them
a-
pregnant.
Will you do ultrasounds to see if how much
They-
is in there?
Yeah, they,
Pockets?
yeah, sometimes they do that like every couple of days. If it's someone that's really on the fence, they'll do that every day. We wheel them up to Dr. Fawcett's office. We have these people on bed rest, on IV fluids to help with that production. So we maintain it as long as we can.
We continue to leak.
It continues to leak.
Have you ever gotten them to go full term?
We've gotten them close, if not, yeah, because once they get to 37, 38 weeks, they're going to let them go.
Are they giving them medication to hold them off also?
You won't want to give these people medications to stop their labor. So if they start laboring, then
So
It's-
bed rest and lateral position is really the only thing.
what's that?
So bed rest and lateral position is.
IV
Tell you now.
fluids. Mm-hmm.
Why are you giving them meds to stop it?
Huh? Because they're ruptured. So there's a difference between allowing someone to stay pregnant that's ruptured who is not in labor than it is to for you to cause them to stay pregnant. Does that make sense?
Yeah, but what's the reason? Baby stable and maybe have fluid issues for years.
The infection.
Well, if a woman's labor is if a woman is in preterm labor and ruptured, and we stop it, and a consequence happens because we kept her pregnant when she wasn't in, or when she was in labor, then poo-poo on us. All right.
What if the mom is adamant about not having a baby?
Huh? What if she's what?
Adamant about not having a baby preterm?
So she wants, so she wants us to, well, I mean, that's a physician decision, so, I mean, they can decide to go ahead and give her stuff to try to stop her labor. But if she's ruptured and she's actively dilating, we might not be able to stop that anyway, so.
Is it pretty difficult
What?
to stop a mom from labor?
A preterm ruptured it is, because whatever enzymes and hormones and stuff are released when that water breaks, that works on the dilation of the cervix, we can't stop that. So sometimes with these preterm people, it's just too difficult. Okay, so here's your risk factors, and again with these, try not to memorize these, but try to understand, and then when you see them, like, yeah, like that certainly could cause rupture of membranes, okay? And here's some more.
Can we talk about the low socioeconomic status? Is that just based on?
So that's probably a
maybe-
risk factor in anything, right?
Yeah. Just nutrition.
Nutrition,
prenatal
risky
vitamins.
behaviors,
Okay.
bad habits,
Okay.
not knowing, not being educated enough to know that I need to go get treatment, not being able to afford to go get treatment, to stop some of these things from occurring.
Okay.
So here's your maternal risks. So of course, if you have PPROM or for your baby, these are all possible, okay? And you can see, and when you look at them, if you have any questions about why it is, ask me, but you can look at these and see why, yeah, that would be that could be a problem. Okay. Okay, so determine duration of the rupture of membranes. So, you know, we want to know when they broke. Okay, so, you know, like I said, we can admit these people at 28 weeks and try to keep them pregnant as long as we can. We're going to be constantly monitoring her for development of infection. And constantly monitoring the heart rate as well. Okay?
Are you doing anything to, like, prevent infection? Are you giving antibiotics or anything like that?
Some doctors may do a prophylactic 24-hour, 48-hour type deal, but not usually. When we have these people on an extended stay, they're not usually on a prolonged antibiotic treatment, maybe initially, but definitely if we start seeing signs of elevated blood temperatures, or if we do some CBCs and we see the C-reactive protein increasing or something like that, we'll start antibiotics and then probably consider doing a delivery if we're suspicious for an infection.
Okay, if there is an infection, will they try to treat first, treat and deliver, or just
both?
whichever?
Okay, so they'll treat and try to get some antibiotics on board for baby that are working,
Okay.
and then deliver, because we don't want to deliver a septic baby. I mean, we're probably going to be delivering a septic baby if we didn't catch the infection soon enough. Okay, if we catch the infection soon enough, we might be able to deliver the baby before the baby starts getting sick, and then that baby would probably definitely go to NICU for very close observation and maybe even prophylactic antibiotics. Okay? But if we get some antibiotics on board before we let that delivery happen, if we can get some antibiotics in the baby, then when we do get delivery, then maybe we will have caught it enough that we don't have some severe respiratory problems with baby. Okay? We can continue the treatment after delivery.
But it's not the infection that's going to cause the delivery.
Oh, it might. Oh, yes. The infection may cause labor,
Oh,
because infection is a risk for going into preterm labor.
okay.
Okay? So if we have these gals in antepartum for weeks and weeks and weeks that are ruptured, we're watching them for infection. Okay? One, because infection will probably cause them to go into labor, and two, we don't want baby to get infected and septic, okay? But if she did not have preterm labor or did not have rupture of membranes and she got infected, and then that infection transferred to baby, then that could put her in labor, okay? If she has a urinary tract infection, that can put her in labor, okay? Because it's just because of C-reactive protein being irritating to the uterus in pregnancy, okay? So if mom gets an infection, that can cause preterm labor. Okay?
But you would rather treat baby in mom
Right.
with antibiotics rather than get baby out and then treat baby.
Right. I would like to get as much antibiotic into baby as I can before I bring baby out. Okay? I mean, we're not going to delay delivery if delivery is what baby needs, like right now this second. But if I have some time, I'd like to get as many doses of antibiotic in mom as I can. All right. All right, so this is what we're going to do for mom. Of course, she's going to be on continuous monitoring. If she's ruptured, we can still do vag exams. But if it's a premature rupture of membranes that's not in labor, we're not going to be doing vag exams because we're just going to set her up for even more risk for infection. Okay? We can see her, if she's not laboring, we can see her cervix on ultrasound. We don't need to be putting our fingers up there and getting it all dirty. Okay? Getting her all dirty. Okay? Okay, so if she's not laboring and she's PPROM, then we don't want to be doing any vag exams because we don't want to be introducing any bacteria. That was a little better, huh? If we want to know what her cervix is doing, we can do an ultrasound. Okay.
Pathogens.
Any pathogens. We don't want to introduce any pathogens. Okay?
Why don't they always use ultrasound
Huh?
to check cervical dilation?
Because the physician needs to do that.
Ah.
If I want to do that, I have to go and get certified, and there's very few. There are some nurses who are certified to do ultrasounds, but this is a physician thing. So, and for a PPROM that we have living there, they will do that, but not for like someone actively laboring. Okay. All right. So placenta previa is an abnormal implantation of the placenta in the lower uterine segment. Okay. This is a risky deal for a pregnancy because this will cause bleeding. And depending on where that placenta is sitting, it may prevent a vaginal delivery. Okay? All right, so the risks with placenta previa are bleeding. Okay? Now there's 4 different degrees of placenta previa. There's the complete previa, and that just completely covers the placenta has embedded over the cervix. Completely covers the cervix. So there is no vaginal delivery with a placenta previa, with a complete placenta previa. Okay. A partial it partially covers the cervix. And again, no vaginal delivery with even a partial. Now marginal, that's a physician decision. The border of the placenta is pretty much right next to the border of the cervix. So maybe a vaginal delivery, but maybe not, okay? A low-lying placenta is the placenta is just down there low in the cervix or low in the uterus. It's not touching the cervix, it's just close, okay? And these people can probably get away with a vaginal delivery. But we just need to watch these people for bleeding. All right, so here's what we look like. So this is just a low-lying, so that placenta is down there close to the cervix but not touching or covering. So she can do a vaginal delivery. Here's your partial. So it's partially covering the opening, and it's just too close. Okay. So as that cervix dilates, it's going to start exposing more placenta. So no. And then here's your complete. Okay.
If you're doing a vaginal exam, what is that? Are you able to tell? That's the
Yeah. Well, I mean, someone who's not someone who doesn't have a lot of experience with vaginal exams and knowing what they're feeling might not realize that that's what they're feeling. But yeah, we can tell, and probably depending on how aggressive your exam is, you may start hemorrhage right then and there.
Are you going to see it in ultrasound?
Yeah. Yeah, they have
So
it
if they have
diagnosed.
prenatal care.
Yeah. So if they have prenatal care, these are diagnosed, and the plan is to watch it because those can migrate. A complete, probably not enough, but the low-lying or partial, they could probably migrate as the pregnancy grows, and then she may be able to do. So they'll be doing ultrasounds throughout her pregnancy to see what we got going on.
So because that area that's over the cervix is more exposed, does it just scab over when it goes over the cervix, or is
No.
it like bleeding sometimes?
So it's
The
it's
whole
probably
pregnancy?
bleeding, yes. Yeah. So here's your risk factors for developing a previa. Of course, the fetal prognosis depends on how much this woman is bleeding and how that has impacted fetal compromise. What? Feta. Feta's good. Okay, so indications for your cesarean birth with the placenta previa is a non-reassuring fetal status, of course. But if she has a complete or partial previa, she's not having a vaginal delivery. Okay, so the bleeding is painless, of course, because it's not so much an abruption as the part that is exposed to the cervix is just bleeding out through the cervix. Okay, so we need to, estimate how much bleeding she is having. So these are just, usually because that placenta is down there, depending on where it is, it affects the way the baby stations herself. Usually those babies are transverse. So while if she is in labor, she's now considered a high-risk patient. So she's on continuous monitoring by most protocols, and then we're constantly assessing mom's vital signs frequently. And then, of course, if she's if she's actively hemorrhaging, like she can be having some bleeding, which is like scant. Okay, so we won't watch her as closely as someone is actively bleeding. So then they fall in the hemorrhage protocol, so they're getting vital signs every 5, they're getting 2 IVs, they're getting all this kind of stuff according to a hemorrhage protocol. Okay. Yeah.
So when they do the cesarean section, are they going to do it pretty almost like premature, just because they don't want her going into labor? Like
no.
If she's got a partial.
No, yeah, they might if she has a partial or complete previa, they'll schedule her for a C-section. And they will probably schedule it at 39 weeks.
Oh, really?
Yeah.
They'll wait that.
Mm-hmm. Okay.
And then they'll just say, if you start going into labor,
right, then we
immediately.
Get here immediately and do the C-section immediately. Yep. So newborn care, depending on how baby was affected with the blood loss or the amount of blood loss, we may be doing some lab work on baby. If the blood loss was severe, then they're going to NICU and they're having fluids and the blood products and all kinds of crazy stuff in the NICU. Okay. But a lot of times just with a low-lying or even a marginal placenta that she delivers vaginally, that she's just not had a very large blood loss. Like sometimes these babies come out and they do just fine. They stay in the newborn side, and just we just watch them a little more closely for 24 hours, and then if they make it through the 24 hours, then they're probably good to go. So babies born of women with previas are not automatic candidates for the NICU. It really has to do with how much blood loss there was and how baby was affected by that blood loss. Okay? Now the abruption is a separation of the placenta from the uterine wall before labor. Okay, because we want it to separate after she delivers, but we don't want to separate any time before that. Okay? So it's called an abruptio placentae, and it's a separation of the placenta from the uterine wall, and there's 4 grades. Oh, wait. Here's your risk factors. So just like any of them, and just like any of the other things, please just kind of think through these and see how, try to relate these to why you think these would be associated with your abruption. Here's some more deals, okay? Male sex.
It's for both of them.
Boys are just problems, okay? They're a problem in utero and they're a problem out of utero forever. No, I'm teasing. You guys are great. All right, so so we have a marginal abruption. So this is just a little part of the placenta is broke away, not all of it. Okay, just an edge somewhere. Okay. And then we have the central abruption where the edges stay adhered to the uterine wall, but the center of the placenta has broken away. So she's bleeding into that pocket. Okay? And you really don't know about it, okay, because it's being contained
will you not see that with the baby not having as good a gas exchange?
Well, yeah, you're definitely going to see it. You're going to
That's
see that something is going on the fetal monitor.
Okay.
But as far as blood loss for mom, you won't be seeing it. It's contained in that little pocket. Okay. And then a complete abruption is it's completely separated from the uterine wall. Oh wow. Okay. So here's the partial or the marginal. So you can see all this placenta is adhered, but this little piece is not, so she's bleeding there. Okay?
Is that bad?
Huh?
Is that bad?
Yeah.
Yeah.
And then here is the central, so you can see the edges of the placenta are all still attached to the uterus, but that little pocket, so she's bleeding in there, and it's not escaping, so you don't know it. You can feel this. This can be a very painful thing for a woman. And if you palpate her uterus, this pocket is going to start getting very, very, very firm.
So how is that different from like a subchorionic hematoma, I guess? Like where would that be?
So, yeah. So, it's pretty much the same.
Okay.
If it's maintained in the tissue. The other one is it's a word I love to say, Kubler, something or other. Okay, and it actually bleeds into the tissues of the uterus. Okay, so anyways, so they're all bad. They're all bad. And then here's a complete. So
Do they all induce labor? Or
they don't necessarily induce labor. They
Yeah.
can.
they're
They,
all candidates?
huh?
Or
Oh yeah, we're getting these people delivered.
Okay.
Okay, we can't.
Even marginal.
If marginal stops bleeding, so these can clot off, okay? And sometimes they go into ultrasound, like when they're, I don't know, let's say 30 weeks. Some people go into ultrasound and they see, oh, you had a bleed. It clotted off, it stopped. Great. She's still high risk, okay? And when we start contracting that uterus, we might cause even more of a problem, okay? So yeah, they need delivered.
Can baby give any oxygen with a complete?
No.
Does that usually?
Yeah, this baby and or mother are going to die if we don't do something.
Can they usually save the kid if they?
If we catch it, yes. If we catch it, we get them delivered, yes.
How do they survive that long? Like even if you're doing an emergency C-section, how does the baby survive off of no oxygen for the time it takes to do a C-section?
Well, for one, there's reserves. Okay, we have oxygen reserves in the placenta, but there. I mean,
Okay.
if we have a complete abruption, we have 4 to 6 minutes to get that baby out.
Is that just because the placenta, it just keeps on beating, so like just like a delayed?
Yeah, I mean the baby's heart's going to keep beating until they run out of circulating oxygen, and then they're going to stop. Okay, they have some reserves in the placenta, oxygen reserves, but we have just a couple of minutes. We got to get this on a complete abruption. We need to get this baby out, and we need to get this placenta out. We need to get this uterus contracting, or we're going to lose mom too.
So what do they? Do they do more like a lidocaine stomach injection really quick? I mean, like it doesn't seem like you have enough time to actually get
Right.
like a.
So in your small facilities in the country where anesthesia is at home, 20 miles out on the ranch, yes, I have. Well, it wasn't because of a abruption; it was because of a prolapsed cord. But I have cut a woman in a bed with lidocaine. I mean, I haven't. I've been the nurse where the physician has kept the patient in the bed with lidocaine. Okay, and lidocaine is she's only injecting lidocaine into the tissue, the skin. Okay, it's not the uterus. Like we're slashing that open. Wait. It took us 7 minutes to get the baby out. Baby's heart rate was 40 for 7 minutes. But anyways,
So they'd be okay.
yeah, they both survived. But with a complete, yeah. I mean, if you're like at CMC, we will probably. I have pushed patients in their bed into the OR. I've bounced off every single wall. I've run people over. I've run over equipment. I'm going as fast as I can. I just tell my patient, keep your hands in the bed. I'm sorry, but I'm going to bump you all the way down. And we've gotten in there, and sometimes we don't even put her on the OR bed. If we have anesthesia in-house, he's putting her out right now. And then it's very fast.
So if they're getting picked up from home from the ambulance, that baby that.
Yeah, baby's done. Okay, let me go quickly. So you guys can read through these. If we have a severe abruption, like mom could hemorrhage so fast that we could lose mom, okay? But she can go into DIC. Here's your baby stuff, okay? Okay, so...
Will the massaging help with that?
Yeah. Yeah, hopefully, yeah. Yeah, and we're going to be given Pitocin afterwards anyways to help cramp the uterus. So here we go. Decreasing the risk for DIC. So you just basically want to be prepared. You want to try to get this woman to stop bleeding. And you might want to be administering blood at a certain point. So usually over 1,000 cc blood loss, they're going to start administering blood, IV fluids, oxygen, and be prepared for DIC, which doesn't matter how prepared you are, it's just horrible. Okay, so I'm just going to run through these. So IV fluids, you know, if they've delivered the baby and we're on central venous pressures and all kinds of stuff, then she's in ICU. Okay, this is beyond the scope of your everyday OB nurse. Okay. Third trimester bleeding. So just read through these. These are probably, let me see, cervical insufficiency. Please let me know. I mean, we have less than 5 minutes left. Please let me know if the remainder of these slides you have any questions on. Please just email me, text me, call me, whatever. Okay? We'll talk about it on the phone, whatever. So cervical insufficiency or incompetent cervix is a painless dilation of her cervix. She does not know it. She may be 16 weeks, she may be 32 weeks, she may be something really preterm, and she doesn't know, but her cervix is sitting there dilating. Okay? So we can do so here's your risk factors. You can look through those. Okay? So we can give some medications to see if that fixes it, but usually what we end up doing is doing this cerclage where we stitch this, the cervix closed. So there's the elective cerclage and the emergent cerclage. The elective is someone that we know has had a history of incompetent cervix. So before she starts dilating, we do this really early in pregnancy. Okay. The emergent cerclage is we found out this woman is dilating, and then we go in and try to stitch it closed and keep it from dilating anymore. Okay. There's an abdominal one. Rarely ever do those, but basically, if this is your cervix, okay, they go in and they just loop a deal around it to act, you know, instead of keeping it from dilating down here, they just loop around. Okay, right. Okay. Yeah. So when they do the cerclage, if she's been dilating, so that pregnancy might be moving down in through that cervix, and she might have a bag of water there, and they have to push that back up and then stitch it closed. And then sometimes when they do that, they rupture the membranes. All right, so we're going to give tocolytics, things to keep her from contracting, antibiotics, anti-inflammatory agents, hospitalization for 24 hours, and then they can go home. Okay, so I didn't put any slides about for multiple gestation. You can look through those. Your amniotic fluid complications, please look at these slides, okay? I didn't say this, but don't worry about reading this part. Only because, like, you probably already read it because that's what you're supposed to do, but I think I was pretty thorough here, okay? So this is a good study thing for you guys. Hydramnios is too much fluid. Okay? Oligohydramnios is not enough fluid, okay? So here's the test what we're going to do for fetal well-being. Chapter 22. Oh my God. Oh my gosh.
There's only like 120 slides left.
Yeah, right. We got chapter 100.
So, yeah.
You could record something on your free time and put it on.
I actually was thinking, I was just going to go through and see how many slides I did have left. There is quite a bit. So I may go home tonight and record from,
There's like 100 slides.
Yeah.
oh my shit.
Yes, I would agree.
Exactly.
Okay, so
Moodle says we have a test next week. Do we have a test next week?
you have a test after next week. So we have this lecture, we have next week's lecture, and then you have your exam. So would you like me to, when I start recording again, would you like me to go back through the amniotic fluid stuff? Okay, so I'll start there. I'll record a lecture, okay? It will be late if at all it gets there today, because once I record it and then I submit it, then it takes a couple hours for that, and then it has to take a couple hours to get to YouTube, and then once it finally gets to YouTube, then I can put it on Moodle, okay? So I'll email you when it gets done.
Thank you.
Okay.
We have mental health until 3 o'clock today.
Oh my God.
Yeah.
It's a non-
Shoot, where's my mouse? All right, hey, and then if you have any questions about the previous exam that you guys just did, that a lot of you did so very wonderful on, email me, please. Okay?
Yeah, you can just go click